Hello and welcome to the Health Professional's Guide to Screening, Brief Intervention, and Treatment. This is part 2 of a 3-part series that we will be offering in the month of September. The first part 1, we focused very much on screening and the use of screening tools and implementing in a variety of hospital settings. And during this session, we will be talking more about how do you move from screening to implementing the brief intervention using some key motivational interview strategies. And I'm Tracy McPherson, and I co-lead the big initiative, the Brief Intervention Group SBIRT initiative, with Eric Goplerud. And my contact information is here available to you, so please do not hesitate to contact me afterward if you have additional questions or you need additional resources, or you're looking for opportunities to receive training and technical assistance during the month of September and October. We have an effort underway, if you're not familiar with it, to provide Joint Commission accredited hospitals across the U.S. that are not funded currently by the SBIRT grants out of SAMHSA. We're able to provide training and technical assistance on a variety of topic areas. One of them is around implementing screening and brief intervention. Others would include around performance measurement, and we still have others that are very specific to implementing in trauma and ED and the business case and the clinical case. And we have a lot of upcoming webinars that are part of that training and technical assistance series that Misty will be able to put up a link for you if you'd like to learn more about our upcoming events or to listen to our archived events that are across those different topic areas. So please don't hesitate to contact myself or Misty, who has been sending out the login and registration information. We'd be glad to help you get involved in the training and technical assistance program that we have. And the webinar today is based on the Health Professional's Guide to Screening, Brief Intervention, and Treatment, which has been developed in collaboration with a number of partners, many of which I imagine you are familiar with, including NIAAA and the Center for Clinical Social Work, EPA, ASAM, ISNA, Peer Assistance, SBIRT Colorado, which is one of those SAMHSA SBIRT grantees that has some wonderful SBIRT resources that I'll be mentioning today and that are available to you and are in the public domain. INSA, Health Teamworks, and of course NORC at the University of Chicago. So all of what you are going to be learning about today is really everyone contributing in their specialty area and tools and resources to try to make implementing in your organizations as seamless and easy as possible. And the objectives of part 2 of this series, of this training, we hope that you'll be able to walk away with a sense of that you can deliver brief interventions that are informed by some key motivational interviewing strategies. And we'd like for you to be able to identify and use some of the sample brief intervention protocols that are appropriate for your setting. And then we will be providing a number of resources around brief intervention that will help make your life a whole lot easier, having a workflow or sample protocol or tools that you can have right in front of you to make it much easier to implement. So we'll be referring to those sample protocols, and Misty has kindly put up a link to the part of our Hospital Big Initiative website where the webinars are housed, including a description of this one. And in that area of the page, you'll see specific links to this PowerPoint, as well as some of those protocols. You'll see the Colorado SBIRT guidelines. You'll see the flow worksheet, a number of really nice sample tools that you can download and we'll talk about a little bit later. But you may want to do that now or do that afterward, and certainly you can always follow up with me if you have specific questions about which tool. But we're hoping by the end of the training that you'll have a sense of what tools might really work in your setting. And just a couple of housekeeping things. We're going to have a Q&A session following the training. So we will do that through the chat feature, and Misty will give us some more guidance on that when we get to the end of the webinar. And this session will be recorded and archived for future access. So if members of your team are not able to attend today, we hope that you will share the link. And again, that's the link that Misty has put up about the webinars and where they're listed. Share those links with them and send it to your colleagues. And it'd be great if they could also listen to part 1 before they get to this archive session, because it might help make a little bit more sense to them. But I would say that if they're very familiar with screening tools already and they're really looking for more on brief intervention, they probably could go just straight to this one. And then part 3, which will be coming up on Thursday, will also be recorded and archived. And I would recommend that folks go through at least this one before attending the third one, but it wouldn't be required, but I think it could be very helpful. We'll be talking about moving from brief intervention into referral to treatment and follow-up. Okay. So we're providing an introduction to screening and brief intervention in this series. And the screening that we covered in part 1 really went through the process of assessing risk. And that's important when we talk about brief intervention, because we're assessing a full range of risk. And that helps us to determine what level of brief intervention we're going to use, and then to help select the kinds of tools and protocols that we want to use to implement the brief intervention. In part 2, we're going to talk about the behavior change strategy and that conversation about motivating people to change or motivating people to take the next step. And that could be, behaviorally, but it could also be cognitively, like their thought process of moving them along that readiness to change process. So we'll be, the key strategies that we'll be talking about come from motivational interviewing, and certainly we wouldn't expect that you be an expert in motivational interviewing following this training, but I would say if you become very interested in the use of these strategies, that you may want to look for a local workshop or other online webinars that can give you some more in-depth information about motivational interviewing, and we could certainly connect you to some of those resources if you're interested. And I would say that the brief intervention part of it, and that we're going to be talking about today, what we see is that there's use of core elements of brief intervention, which we'll talk about. And in some cases, there are hospitals, other types of medical settings who choose not to use the motivational interviewing piece. They start out by training on the core elements of brief intervention. So the protocols that you're going to see are going to have are going to vary in depth and breadth. They may focus just on those elements of brief intervention. Others you're going to see weaving in the motivational interviewing strategies. So you do have options. Some would say that the motivational interviewing strategies may be that secret ingredient that when combined with brief intervention is really what helps move people along in their thought process and in their behavioral process. But it does give you options, and I would say that often, if you use more motivational interviewing strategies that we're going to be talking about, that can tend to take a little bit longer in the process. So keep that in mind and try to think about, well, as we're going along, who might perform or conduct part of the brief intervention, say one type of health professional where there's a patient encounter, and where might that patient be handed off where more brief intervention might occur, where the motivational interviewing might occur. Just keep in mind that the same person doesn't have to do all of it, but we'll give you that full picture of what it would look like if someone was doing all of it. And then in part 3, we're going to talk more about linking our patients to the specialized addiction treatment and even recapping from where in the screening process do we determine whether someone needs referral to treatment, or as we're conducting a brief intervention at that level of risk, how do we hand off someone in a warm handoff, preferably, to that next level of care, and how do we support patients and sustain their successes along the way. So hopefully this gives you a nice overview of what this series is about, and hopefully you will be inspired to attend all of these, either archived or coming up later this week. So let me just recap quickly for those who may not have been able to look at the archive or weren't able to attend, just to give you some context about how do you move from screening to brief intervention. We talked about the 4 patterns of alcohol use in the general population of adults. And we talked about the understanding the levels of risk and how screening tools help us determine the level of risk based on whether individuals are consuming alcohol above the safe drinking or low-risk drinking guidelines, and whether they're experiencing harmful consequences or have dependence-like symptoms. So the screening tools around alcohol help us with the items that are addressing those factors, where they are in that continuum of risk. And so we talked about how most of the population is at a very low level of risk. Either they don't consume alcohol or never exceed those guidelines. That's that 75% at the bottom. And those individuals will get a brief intervention, but you'll see it's at a lower level of intensity. And then as you move up the pyramid and the level of risk increases, you see the moderate risk and the high risk. And these individuals are exceeding those guidelines and experiencing some symptoms, maybe even dependent symptoms for those at higher risk. And our screening tool is going to help us interpret what level of brief intervention and the elements of the brief intervention that go into the moderate risk that make it a little bit more intensive than what someone at a low risk or no risk range would get. And then even further as you go up, the high risk. So what kind of intervention, what goes into that intervention, and what would be warranted at that level, at a more intensive level of intervention. And just to make sure that we're all on the same page to recap, the workflow that we're talking about here, the patient flow and where people are going to receive screening and brief intervention and the referral to treatment that we'll talk about in part 3, that can look different in different hospital settings, and different people may play different roles or do different pieces of it. But overall, at a macro level, the process is generally the same. And so we have patients arriving in the healthcare setting, and there's an initial contact at some point, and there may be a health screen, a triage process. This is where the basic information is collected, and this is where your pre-screening, your 1-item, 2-item, 3-item screeners, or either a more global brief screener, could be something like an 8-item screener that has one question on alcohol, one on drug use, one on tobacco use, one on depression, one on suicide, and so forth. So it's that level of screening that happens there. And then based on the information gleaned from that initial contact, you would determine whether a more full screen, such as the use of the AUDIT tool or the DAS drug use tool, would be fully administered and then scored, or whether there's really no AUDIT risk, which stands for alcohol, tobacco, and other drug use. There may be no real risk factors there. And so based on determining from at that point and going through the screening, you would determine that level of risk, that low risk, moderate risk, through high risk. And those results and the interpretation of the scores really help guide us in determining, as you can see, those different levels of intervention that are noted here. And then from that point, there would be a referral to follow up for those who are in the higher risk range, or it may be that you're following up for moderate and complex cases, and we'll talk more about that in Part 3. But this just gives you the basic overall workflow of SBIRT sort of generically in a healthcare setting. We talked about in Part 1 that we're focusing on the use of the brief screening tools that look at quantity and frequency and consequences of use that, as I mentioned, like the audit will help capture all of that information and help determine the level of intervention. And we talked about the use of tools and variety of administration methods, and we also talked about the ability to use those tools in face-to-face or telephonic encounters. It's the same with brief intervention. The brief interventions can be very brief. They may be very, very short in duration, or they could be longer, and it may depend on what type of practitioner is going to be doing the brief intervention. And the brief intervention could be face-to-face, or it could be telephonic. So, you know, you have a lot of options when you're implementing this in your organization. And we introduced screening as a routine standard practice, and that's what we would propose here, is to introduce the brief intervention right after the screening as part of routine practice at whatever level of intervention would be warranted based on that screening. So it becomes part of just what you're doing every day, and embedding the screening and embedding the brief intervention into your existing processes so you're not disrupting the flow, the operational flow, and you're selecting the tools, the screening tools, and the brief intervention protocols that are really the best fit for your organization. And that's what's key. It's making sure it's the best fit for your operations and what you're trying to achieve with your program. And those are the tools that we recommended and that we provide a lot of information on in the webinar, but we also have, you'll see on the website in that same area where the archived webinars are that Misty's provided a link to, you'll be able to download all of these tools. Now we'll be focusing on using brief intervention in the context of alcohol use for the purpose of this webinar. And I would say that what you'll find is that many of the elements that go into brief intervention for alcohol use are often used for tobacco and drug use, single item screeners for ATOD. So it's the framework that we're hoping you're going to take away, and it's the non-judgmental style and the approach that we find if people can focus on learning it around alcohol and sort of get that sort of firm in their mind, it's easier to generalize that framework and those strategies and those conversations to other substances. So we're not exclusively saying that what we're going to talk about today, it only applies to alcohol use, but we would encourage you to use these strategies when you're talking to someone about cutting back on smoking or quitting smoking, or it may be around the use of prescription medication above the prescribed levels, and so forth. And I would also mention that there are a number of protocols and guidelines available to you around prescription drug misuse, tobacco use, that we can provide to you. We've put up a lot of handouts today, but we have more. So if you're really wanting to also do tobacco, we have some great tools available for you, as well as around fetal alcohol syndrome, if you want to integrate SBIRT in those contexts with women of childbearing age, or if you're doing work with HIV patients. We have some protocols available for you for that as well. And we talked about the use of a standard drink. So I'm not going to go through this, but just want to recap that it's important when you're moving into your brief intervention, you really have an understanding of the level of risk. And so it's important to get an accurate screen, and the use of the standard drink chart will help you when you're working with the patient to get an accurate screen, which in turn helps you to get more accurate results from a screening tool, which will then help you to be more accurate in determining the level of risk and the level of brief intervention. And we talked about the audit C, and went through the full audit as well as those other tools. And what you may recall from that is that the tool allowed you to bracket what the risk ranges were. So with the audit tool, you may recall that after giving the 10-item screener, that a score of 0 to 7 was low risk, and that people at that level are going to get a low level of intervention. Those at 8 to 19 are in the moderate risk and moving towards that moderate high risk and experiencing potential harm. So this is really where you're going to see a lot of the meat of the brief intervention taking place that we'll be talking about. And then in the score of a 20 to 40, the high risk range, possible dependence, you're going to see the ingredients of the brief intervention, but you're also going to see the referral that's warranted at this range. So everything really starts from that screening and the interpretation and understanding where that patient is in the risk, in the level of risk. So let's talk about moving into the brief intervention from screening. So at this point, we're assuming that the patient has been administered either a pre-screen and or a screening tool. We're going to say the audit, for example, and that it's been scored. It's you now have the risk ranges. You've determined the level of risk, and you want to move into the brief intervention. Now, this may be you doing it, or you may now be at a point where you've handed it off to someone else who is going to do the brief intervention. So brief intervention is defined as a behavioral change strategy, and it's going to really vary in length and duration. Some are very, very short, 30 seconds. Some can extend 3 to 5 minutes, 15 minutes, 30 minutes, could be more than one session. It really, the protocol that you choose and the constraints of your environment or the processes will play into how much time you have to provide a brief intervention. There are certain contexts, perhaps in trauma and other departments, where the one practitioner may not have the opportunity to spend 15 minutes with someone, but there may be a staged approach where the physician or other healthcare professional can do the screening and some initial feedback, which may be about a minute, and then it's extended off or handed off to the next person who would then perform that brief intervention, which may range then and extend that first brief intervention contact to much longer. And you know that I'm sure you're aware by now, and if not, we'll be glad to provide you resources on it around the billing and reimbursement for SBIRT and the definition of those billing codes, which do have requirements around the time that is spent doing the screening and brief intervention. So 15 minutes is one approximate cutoff, and the other is 30 minutes. And so you have to think about that if you want to be billing, and who has the time to be able to do that. If you're not billing, then I guess you have a little bit more flexibility in the depth and breadth of the interventions that you provide. It's important to keep in mind this will help many people, but it's not going to help everyone. We would recommend somewhere immediately following screening within the 24 hours, but a gap of a few days or a few weeks does not seem to dilute the effectiveness. In many contexts, people will be discharged, and so it wouldn't potentially make sense to do something a couple of days later. Maybe they're admitted, and it would, and you have 24, 48, 72 hours to have someone be able to provide brief intervention. So it doesn't seem to dilute it, but certainly seizing the moment that and really connecting if there is an alcohol-related injury, or there's some other alcohol-related event, or there are alcohol-related health consequences or emotional concerns, the immediacy of linking screening and brief intervention and why the patient is there, certainly seizing that moment is important, and that could be lost if it's days later. It may not. It would perhaps depend on the intensity of the experience for that person. But certainly you have some flexibility in the time frame that you're going to deliver it. Now, the brief intervention ingredients, the components of brief intervention, whether you're going to choose a framework, if you're familiar with some of the frameworks that are out there in the SBIRT literature, or the 5 A's, and there are the basics. There are many others, and many of them, if you look across them, have very similar components. What they call them might be something different, but you'll see they map pretty well to these categories or components of the intervention. So the first is feedback around the audit score. So after administering the screening, getting the score, you're going to provide some feedback around the score. You're going to talk about how the results compare to the general population. That's normative feedback, to the norms. Provide expression of concern about the potential effects of unhealthy drinking, and making the connection, if you can, to the patient's health concerns or other reasons why they may be there seeking health care. You provide advice to cut back. You can explore the pros and cons of their use. Work with them on action planning. It used to be called goal setting, but action planning is any steps. It could be very small, it could be large, and it could be in their thinking process, it could be behavior, but getting them to commit to something to move forward that they can do. So those are the central components, and what we're going to also show is the strategies that can be woven in from the motivational interviewing literature into this basic framework. So as I mentioned, some frameworks just really work with these kinds of elements, and we're going to show you some micro skills in the motivational interviewing world that can help facilitate having this conversation and eliciting communication, eliciting dialogue and motivations to change, eliciting reasons to cut back or to quit or to do something different. We're going to show you some of those. So the skills really necessary to provide brief intervention are not new. You may have learned these I was working with some nurses, and they were talking about effective communication, constructive communication, other kinds of courses that therapeutic relationship or communication, those skills. They learn them in a different way, and so some of this may sound familiar to you. You may be able to connect it back to other skills that you've learned, but it's what many health professionals have been taught to do, to listen and to elicit, and it's just refreshing some of those skills or presenting them in a slightly different way in the context of SBIRT and talking about alcohol use and other substances. And so we know that the use of SBIRT is growing in medical settings, and a large body of research does support the effectiveness of it in primary care and in hospitals. And there are volumes of literature out there to support working in a variety of medical settings. And so we would like to point you, if you are interested and want to learn more about the evidence behind it, we would encourage you to attend the clinical case webinar that will be available to you also from our website. And we want to point you to some additional resources that may be useful. If you want to learn more about the research, you want to work with your staff to share what the evidence is, to get their buy-in of why we want to do brief intervention, why you're asking them to do brief intervention, why is it effective, how will it help them, and how will it help their patients. And so we have summarized here for you some of the findings in the various study settings, and have given you some citations, and we could certainly provide the full citations for you if you're interested. They often come up in a very quick Google search. But this will help you too if you have to speak to leadership and you're trying to get that buy-in with your stakeholders or hospital administrators or others. This makes some, this really can inform some quick talking points around that you can use in your own PowerPoints. Okay, and for your convenience, I've listed here 2 volumes that are available to you, and they're public domain available from NIAAA. If you're not familiar with these, they have the full research articles that are available to you, and it will give you specific studies in different kinds of medical settings that you can use again to help make your clinical case, your business case for why you want to do brief intervention, and all the things that we're going to jump into now. And here are some additional pieces of information that can be very useful in making that case, helping stakeholders to understand that the U.S. Preventative Services Task Force and the World Health Organization have reviewed the research and for screening for unhealthy alcohol use in a variety of medical settings is effective, and it is part of the recommended standard practice for working with adults. And that there are many international health organizations, professional associations, and business groups. And I think I did a review a couple of years ago, and I think it was over 23 different organizations, well-regarded professional organizations and federal agencies. And we do have a literature review available to you. It's a white paper I'd be glad to send you. It's really my own literature review that can really sum up some of this for you. But it was really very powerful to see how much evidence and what has really moved these organizations like the American College of Surgeons Committee on Trauma to require level 1 and 2 trauma centers to provide SBI to remain accredited. So this is really becoming good standard medical care because it works. And so we, as part of the big initiative, are really helping you to move this into routine practice. So there is the link to the business case for the hospital SBIRT webinar that Eric Goplerud did a few weeks ago, and you can you can not only listen to the archive, but you can download the PowerPoint presentation. And we're going to have some literature available to you if it's not already up on our website. We will be putting additional materials on the website that speak to this. So moving to from screening to brief intervention, we've talked about determining the level of risk, and I imagine you're all convinced that there's enough evidence to support that we have a great opportunity to seize the moment and to help provide the right level of intervention for those who likely did not come and present to you for alcohol use. So we're keeping this in the context that we're implementing this when people are presenting for many other different things, many other health concerns, physical, emotional health concerns. But we've taken the opportunity, we're seizing the moment to determine risk and make the connection. Here are the elements. When we talk about those elements a minute ago, when you look, well, where do they fall when you're talking about the level of intervention? For someone who is at low level of risk, that's 0 to 7 audit score, you're going to provide the feedback around the audit score, and you're going to inform them about safe use and reinforcing and congratulating them that they are consuming alcohol either not at all or within the low-risk guidelines. The moderate risk, the 8 to 19, they're going to receive the feedback around the risk. They're going to get the comparison to the U.S. Epidemiological studies in terms of the prevalence, the norms, how do they compare to other people, other healthy adults their age. We're going to inform them about safe use, how to, what is the safe drinking guidelines and how to stay there, or recommendations around cutting back and advising them on how to do that, and hopefully eliciting from them ways of doing that on their own. And using the motivational interviewing. And if you're a practitioner who uses cognitive behavioral strategies, we won't be talking about those today, but if you already are using those, this is a place where you would weave in with the motivational interviewing those kinds of CBT strategies. And so if you're working with a social worker, a licensed clinical social worker, or a psychologist or other kind of behavioral health care practitioner who's working with you to provide the brief intervention, this is where a lot of the training that they use to communicate and help move people along, this is where they come in and where a lot of their skills are really optimally used, is right here. And then to generate change statements, we're hoping we can elicit change statements, whether they're small steps forward or they're big steps forward. But smart, realistic goals, we hope, and to help them to generate reasons for taking a step forward to meet those goals. And then the option of follow-up. For some organizations, they have the opportunity to follow up with people. They may integrate follow-up into their annual visit. It may be that they're coming back routinely as a part of diabetes management, weight management. There are a variety of health conditions where you could do a check-in and do a very brief check-in, kind of brief intervention, making a connection to the other conditions of which they're seeking health care in that moment. So you could do that. In the high-risk category, you'll see that this group is going to get everything that the moderate risk group gets, but they're also going to get, this is where follow-up is really warranted, and where referral to addiction specialists or for intensive services, more intensive services, it may be addiction treatment provider, it may be a physician who is aware and is licensed to prescribe medication-assisted treatment. It could be a variety of resources that work for that particular patient. But we really need to get them to another level of care. And I would say that this is where follow-up and continuing monitoring is I'd say it's important for any level to make sure people are staying within the guidelines and making change. But you really want to make sure that you're following up and monitoring a patient at high risk, because they're likely experiencing dependence symptoms to a point where it's interfering with different domains of their life, their health, their work, their job, their families, and other aspects. So we talk about providing feedback about risk. So you may recall from our Part 1 session when we're introducing screening that one thing that you can introduce to everyone, which you can ask everyone regardless of what people are coming in for, is do you sometimes drink beer, wine, or other alcoholic beverages, even before you think about administering a screening tool. This is a way to determine who really needs further screening or not. And with this question, you can quickly determine whether the 40% that was in the drinking pyramid, that the no risk, meaning that they don't consume alcohol at all, whether they would even need a brief intervention. So this is really for someone who says, yes, I sometimes drink beer, wine, or other alcoholic beverages. Even those individuals are going to get some feedback, whether the answer is no or yes. So the feedback for someone who says no, that there's a no risk, they're going to get congratulatory feedback. They're going to be reinforced that that they're not consuming alcohol, that keeps them obviously at low risk for developing a medical disease of alcohol dependence or experiencing complications, emotional, physical health concerns. You're going to give them some congratulatory feedback. So let's assume that someone said yes to that question. They moved on in the process and were administered the audit screening tool. And the first three questions of the audit, you may recall, are called the Audit C, and they focus on that consumption piece, the frequency and the quantity, that standard drink chart that really helps you get an accurate quantity and frequency measure. Let's assume that you use only the Audit C. There's three items, and you don't use the full audit. The score, you may recall, for men of 4, or for women and older adults, a score of 3, that's considered a positive screen. Or if you decide to use the full audit, you would have a score of 7 or below. And this is the opportunity where you're going to inform the patient that they're at low risk for alcohol-related problems. You're going to encourage them to maintain these healthy levels. You're going to congratulate them and encourage them to remain that way. And here's an example of what you might say. So, John, your answers to questions about your alcohol use indicate that you have a low risk of developing the medical disease of alcohol dependence. Keep up these healthy patterns. Very simple, very straightforward, a low level of intervention, but important for the patient to keep remaining that way or stay low. So for someone scoring in the audit range of 8 to 19, you want to inform them that they're at moderate risk for developing health and emotional concerns, potentially work-related issues, family issues, and then it's really key here, if you've heard something from the patient that suggests that alcohol may be interfering with something in their social life, family life, work life, if you have information about their health, their lab results, maybe it's related to an injury or accident or something else that they're a physical health issue that they're seeking healthcare services for. This is a really prime opportunity to make the connection between moderate risk and what they're experiencing. And so having really good listening skills is so key so that you can make that connection, hearing what their concerns are. So here's an example for someone who scored in the moderate range for the audit. Maria, your score on the audit was a 14 out of 40. This suggests that you're at moderate risk for developing the medical disease of alcohol dependence. Your drinking greatly increases the likelihood that you will have an alcohol-related accident or begin experiencing health or other problems. I'm concerned for you. So that you see it's very straightforward. It's factual. It's non-judgmental. It's not moralistic. We're not stigmatizing people. We're trying to elevate their awareness and concern. Now, this is something to be applied to anyone, but certainly making and furthering that conversation and making that connection, you really have such a prime opportunity that other contexts don't have when you're in a medical setting. You have information about that patient that's so rich that in some behavioral health settings we don't have. So a real opportunity for you. A feedback for an audit score of 20 to 40, we really want to inform the patient they're at high risk of developing the medical disease of alcohol dependence and acknowledging that it's likely they're experiencing problems at work, at home, and in their health. And if they haven't articulated that to you, sometimes this kind of feedback can elicit that disclosure and that building that rapport, and you're expressing concern and they want to open up that maybe they are experiencing other things that are going on and that are problematic. So here's an example. Edmund, your score on the audit was a 33 out of 40. This is very high. The amount that you drink and the symptoms you report place you at high risk for alcohol-related illness, including the very real medical disease of alcohol dependence. You are probably experiencing some problems due to your drinking, which may already be severe. I'm concerned for you, and I recommend that you cut back. Again, very non-judgmental, very informational, very direct, and it expresses some concern that you really are concerned. Now, this may be the first time anyone's heard this. It's possible. Some people are not aware that their range of risk is this high. People in the moderate range are also often surprised that they're in a moderate risk range. So you have to keep in mind, this may be the first time they've heard it. They're coming in and presenting for something else. They're trying to make the connection. This is a sort of a process of working with them as their mind is having sort of wrap around this new information that they weren't expecting to experience. It's really important how we deliver it, and I think sometimes it's more about how we deliver it than precisely what we say. But this scripting helps provide you some general guidance that can help you begin to have this conversation. Well, we've just informed them about their level of risk in the context of their screening score, and it's now a really good opportunity to discuss with the patient that level of risk and their drinking patterns, and help to provide them with some clear guidance on what healthy drinking looks like. You can ask them, would you be interested to know what the low-risk drinking guidelines are? Certainly asking them permission along the way is a very respectful thing to do. You could also just offer the information. You could say, I'd really like to give you some feedback about the guidelines around low-risk drinking that could help you reduce your risk, or give you a great a guideline. So when you're out with your colleagues, or you're out at a social event and you really want to stay low risk, here's something that you can remember. We have a simple rule of thumb called know your numbers. For men, it's no more than 2 drinks per day, 14 drinks per week, or 5 drinks per occasion. For women and men over the age of 65, this is all older adults, it's the 174, no more than 1 drink per day, 7 drinks per week, and 4 drinks per occasion. And ask them, so what do you think about that? The 2-14-5 rule, is that something that you might be able to keep in mind? Or how about the 174, of course, if you're talking to a woman or an older adult? What do you think about that? For pregnant women, if you're working with for pregnant women or women of childbearing age, there are different considerations if they're trying to get pregnant or they are pregnant. There are also different considerations for those under the age of 21. From a policy perspective, no alcohol use would be the recommendation. That would be the guideline for anyone under the age of 21. But I would also say that if you look at the CRAFT tool, they acknowledge that it may be policy, but we have real behavior, and we have to deal with that real behavior. And saying no alcohol is recommended. We recognize that you are consuming alcohol, and though we would like you to abstain, we're going to work with you to move you to that point. And so let's work with you at your level of risk, moderate, high risk, and let's work towards moving you in that direction. So we acknowledge what the guidelines are, and we help to be sensitive that we understand it may be an illegal behavior for some people that you're working with, but you want to extend to them and develop the report and say, we want to help you move towards reaching, whether it's abstinence or moving to moderate risk or low risk, whatever that path is that patient is choosing. So we provided the screening score feedback where we've expressed now at a very entry level some concern. We'll do that a little bit more. We've given them some guidelines. It's sort of a natural place in the conversation to talk about normative, what we call, give them some normative feedback on how they compare to other people. So, for example, if you're working with a patient who is scoring in the 8 to 19 moderate risk range, we know they're exceeding one of the recommended guidelines, either that 174 or 214.5, and they're at moderate risk, you will give them feedback that they're actually in the 80%, they're not in the 80% of the population who never exceeds those levels. They're only in the 20% of the population who exceeds these levels. And people don't like to be in that smaller group. They are often surprised that they're in the smaller group. There are a small proportion of people who exceed these guidelines because they're socially or in their family, they've seen that this is maybe what's going on around them. Everybody drinks at that level, and so this could be new information for them. When you get to the high-risk group, again, being part of that 5% who exceed these guidelines, it's not a comfortable place for many people, and they may be surprised. And then the people at the bottom, the 35 to 40%, they like being in that place because they're part of the larger group of people. So people are in the low-risk range always drink within the low-risk range. They don't exceed those guidelines, and you can say that 75% of the population, you're in that 70% of the population that never exceed those low-risk drinking guidelines. We find that people respond to this feedback, and we don't know from the research or the science that this is the secret ingredient, but it's interesting when we look at the studies that we've done and we get feedback that people are surprised, it's an aha moment, it tends to elicit some conversation, they feel uncomfortable, it creates that cognitive dissonance of sort of being in that place, and it seems to help motivate people to think or do something differently about cutting back. But just it's just an anecdotal piece to. It'll be interesting to see whether you have that experience as well. Here's an example of the feedback that you might provide for someone who's at the 0 to 7 low risk range for the normative feedback. I would like to give you some feedback about how your drinking compares to other adults. May I? More than 1/3 of the U.S. adults do not drink alcohol. Almost 3 out of 4 adults either do not drink or drink at levels that are not considered unhealthy. Those levels are below 14 drinks per week or less than 5 per occasion for men, and below 7 drinks per week and less than 4 drinks per occasion for women. You are in this healthy, low-risk group. Keep up these healthy patterns. Now, I want to acknowledge, too, that you have to take into account the patient. This is assuming this is a generally healthy patient, healthy adults. You know the health history, and you have to place that in context with this. For some people, no alcohol use because of another condition would be recommended. So if they are drinking at all and they're in the low-risk range, that still may be contraindicated for medications that they're on or just whatever's going on with them physically or mentally, emotionally, or there's a family history of alcoholism, or they have been in recovery and they've relapsed. I mean, we have to take the whole person into context when we're providing this kind of feedback. So for someone who's in the 8 to 19 range, here is a way to provide the moderate risk normative feedback. Would you like to know more about how your score compares to other adults in the U.S.? Nearly 3 out of 4 U.S. adults drink at levels below yours. If you reduce your drinking to 4 or fewer drinks per day or 7 or fewer drinks per week for a woman, your risk of alcohol-related health problems will drop significantly. Would you be willing to consider how to decrease your risk? For someone at the 20 to 40 range, the high risk, potentially life-threatening alcohol dependence impacting work, family, and health problems, the intensity of that feedback, it has a different tone. And again, it's a tone of concern and not judgment, but it's to help put into perspective where they are. So your current use of alcohol is more than that of 90% of U.S. adults. This pattern is harmful to your health and could be causing problems at work or home. Men who drink more than 14 drinks per week or 5 or more drinks on an occasion put themselves at serious risk of health and emotional concerns. Would you be willing to consider how you could reduce your risk? So at that point in the conversation, there is an opportunity now to provide them some alcohol education. And we've given them sense of risk. We hope we've built some awareness around risk. We've given them some feedback about how they compare to others. We hope there's that likely motivation to at least think about doing something different, maybe staying within the recommended guidelines. And so we've given them know your numbers, but we also want to give them some information they can take away from them, whether it's electronic or it's a physical patient education material. For many people, even for a low risk, you can give them something at a very low level. It will help them to remember what the drinking guidelines are, some very low-level education just to support that they are drinking within those guidelines, tips for staying low risk. So there's that level of education, and then there's more intensive levels of education that have that, as well as activities around how to cut back. It may go into some goal setting, something that they can actually take home, work on. They can even talk to a family member about. So we have a couple of suggestions about the kinds of materials that you can use. And certainly you probably have your own education materials around making the connection around hypertension, diabetes, cardiovascular disorders. And so we would encourage you to pair the materials together or look at other resources that do talk about the use of alcohol with these other conditions and have those available in the patient rooms or out in the waiting rooms or so forth. One way to provide the education just verbally is, for example, for low risk, is to say something like, John, you have a low risk of experiencing problems associated with your drinking. If you continue to stay below the guideline levels, the 214.5, your alcohol use may even be healthy. Congratulations. So I would pair that with the materials. For someone at the moderate risk, alcohol education might take something of this form. Fewer than 1 in 5 adults drink as much as you. The World Health Organization found that drinking at this level may be hazardous. Adults who drink this much are at a much higher risk of developing alcohol-related health problems such as gastrointestinal distress, conditions, health concerns with your pancreas, liver diseases, cancers, as well as having potentially dangerous accidents at work, at home, and on the road. The amount that you drink also puts you at a 1 in 5 chance of developing alcohol dependence. Or your pattern of drinking places you at risk for experiencing health, emotional, social, financial, occupational, and other legal problems that I'm concerned. Would you be willing to discuss how you could reduce your risk? I'd like to give you some materials that we can talk about here, some educational materials, and like for you to take home. And when you come back for your follow-up visit, I'd like to talk with you more about that. And same for the alcohol education for the audit score of 20 to 40 for high risk. Edmund, I'm concerned that your drinking puts you in danger of problems with your job, your family, and your health. You may be well on your way to developing the medical disease of alcohol dependence. Roughly 50% of people who share your drinking pattern have or will develop alcohol dependence, a serious and potentially life-threatening disease. Fortunately, many people with your level of alcohol use are able to significantly reduce their risk of alcohol-related accidents and health problems by changing their patterns of use or stopping alcohol consumption or all, or stopping drinking entirely. Would you be willing to discuss how you could reduce your risk? So here, those are the examples that you might deliver verbally with along some of these materials. The NIAAA Rethinking brochure, Alcohol in Your Health, really answers a lot of questions about health risks and common problems associated with unhealthy alcohol use. It's great if you can mention some of those in that dialogue and make a connection between something going on with that patient. But if you don't have, the time to make as much connection as you like, but you may have hit on it, this is a good resource because it does make the connection around other health risks. They can take it home, you can open it up, you can show them, you can ask them to take a look at this and come back and discuss it with you in their follow-up appointment. It's a wonderful resource. We have available for you to download the electronic copy of that, and Misty has made those links available to you. There's a companion website that you can use. I recommend, and you may not be able to do it right then with the patient, but it is listed in the Rethinking Drinking brochure. It has a lot of the same information, but it has some interactive activities in it as well. It has a cocktail calculator for people who are trying to figure out, they drink fancy drinks and they don't know how much really they're drinking, or they want to talk to a family member about their drinking. It's a nice, interactive tool that can help facilitate dialogue, whether it's with family members or between you and your patient. It's got a lot of really interesting features that what we hear anecdotally is that patients really like. You have the opportunity to order these in very large bulk quantities where it says take it with you, download now, or order. Those are some wonderful, they're free tools that can be ordered for your waiting rooms and so forth. They're currently on back order, but I'm assured that they will be in stock before long. And then there's some additional materials for you. This is just a larger picture of it so that you can see some of the things and where the download is, and the cocktail calculator and some of the other information. That's just what it looks like. I would say one thing, though, that if you're going to recommend something like the Rethinking Drinking, is to encourage you and your staff to go through it yourselves before you actually recommend it, or take the time, 5 or 10 minutes to go through the website and find out what's there. And so if you think you've already been through it and you can tell your patient, there's this terrific resource, I've reviewed it, I've gone through it, there's some great material around strategies for cutting down, and I would suggest if you don't have time to go through the whole thing, you start here. There's something about making that connection with the patient to say that you've read what you're recommending, and here's a specific thing that I recommend that might be able to help you. So I would encourage all of your staff to review things that they're actually recommending. They're more likely, I think, for people to actually pick them up and take them away and read them instead of just collecting dust somewhere. So here are a couple of other resources. Tips for cutting down on drinking. We talked about the low-risk individuals who may need a lower level of education. Certainly everybody can get Rethinking Drinking, but this is a little bit even more simple. Just tips for people to stay low risk, to stay within the guidelines, and have standard drink charts. And then this next one, which people really like, it really helps both staff to understand what are the harmful interactions between alcohol and medication, because they may not be as familiar with the complications and the contraindications. Obviously, there are medical professionals who are well-versed in this, but there are many professionals working in the medical setting who aren't. And having a tool like harmful interactions helps them educate themselves, educate their patients, and give the patients who are on a variety of common medications something to take away so they understand. We find that people don't always read the fine print that's stapled to the prescription bottle, or even read the yellow stickers that are on the side that say no alcohol consumption. So this is a nice tool for you to use, and again, it's very difficult to actually memorize all the content in it necessarily, but if you can at least be familiar enough with it to know how it's useful, I would recommend your staff to at least take a minute to go through it. And then if you're looking for more education resources, more online resources, links, and so forth, we have now available to order the health professionals screening and brief intervention and treatment guide, which has a lot more in there for you. These are just a sample of those that are available to you, and you could contact me if you want more information. And certainly there are a variety of practitioners in the hospital. It may be that you're doing a brief intervention before the patient has ever seen the physician or other professional. And so, you have an opportunity to then encourage your patient to use the resources you've given them, and then to encourage them, if you know they're connecting with the next provider, to have a conversation with that physician about it, even if it's not why they came in, but encourage them to have a follow-up conversation with that next healthcare professional they encounter. The next part of the brief intervention, which is sort of a natural place to offer this after you've provided the screening score feedback, the normative feedback, understanding the guidelines, and providing the alcohol education. We've talked about expressing a concern. You saw some examples of doing that up front and helping to build the rapport and to understand that you do feel like this is a concern, even at the moderate, risk level. They're picking up that you're concerned that they're drinking above the guidelines. And here are some additional ways to express that concern and provide some advice on what to do about that. And they may not know what to do. Some may come up with their own ideas. We certainly hope that they will. But we're often in the medical setting very capable of giving advice. And what's a little bit different about screening and brief intervention when you're moving the motivational interviewing strategies and weaving those in is that from a motivational interviewing perspective, you wouldn't just give advice. What you would do is you would ask permission to give advice or ask them if they would like advice. We don't often do that in the medical setting as much, but this is where you have the medical and the behavioral health field, the SBIRT and MI sort of coming together, and it's the synergy of the two, and certainly asking permission or asking people if they want that advice is just a respectful way to maintain that conversation, that level of rapport, and let that person feel like you respect them. So for patients whose drinking puts them in the moderate to high risk categories, the simple advice may be around reconsidering their drinking pattern, or it could be cutting back. It could be abstaining from alcohol. It's different for different people, but certainly SBIRT is a harm reduction approach, and cutting back is an acceptable recommendation for all levels of those two risk categories. The concern and advice, the key is that it's non-confrontational, and it is generally expressed with concern in a way that the tone motivates people to think differently, do something differently, consider change, or to rethink their use. So again, it's the delivery of it that's so key. So I would encourage you, if you have clinical supervision or opportunities to practice, you can practice the tone on your family, your friends, supervision time. There's many places to practice delivering information in a non-judgmental tone, and the more you do it, the more it becomes part of what you do, and I think that's really the key. So here's an example of what you might say to your patient when you're expressing concern and offering advice. So have you considered cutting back on your drinking? Reducing your alcohol use could reduce your risk of problems, and cutting back could really help you concentrate on the problems that led you to come here today. I'm concerned that your drinking may make things worse, and I think following the recommended drinking guidelines would help make things better. If you're not ready to change, you might consider doing one or more of the following things. Or you could say, I think following the recommended drinking guidelines would help make things better. What do you think? What might you consider, or what are things that you think that you can do to cut back on your risk? So you have the opportunity to elicit their own ideas before offering the advice. And so some of them that you might frequently hear are the following. If they say, I have no idea, you can say, well, would you like some suggestions or things that have worked for other patients? And you could say, okay, some of the things that have worked for other patients are keeping track of how often and how much you're drinking. You're keeping a drinking diary, just jotting it down on a piece of paper, and just keeping track of it for a week or two. Notice how drinking affects you. Do you feel differently? Do you think differently? Do you act differently? What's going on around you when you're drinking? Is there cues in your environment or things that are happening around you that make you feel like you're more likely to drink? So you hear that around people who smoke cigarettes, and they might pair cigarettes with drinking, or they go to a bar and they automatically would order a drink rather than an alternative beverage. I mean, there are relationships with alcohol and effects both emotionally and physically that people may associate with drinking that may encourage them, or just may not encourage them, but they may not think not to drink. So you want to have them be more in tune with what they're thinking and feeling. You could have them list pros and cons of changing their drinking, because with every pro of cutting back, it's possible there's a con. It could be that cutting back on the number of times they're out with their friends or at a social event drinking. Cutting back may mean that they feel risking some relationships or peer relationships, or could cause tension with their peers if they were to change their behavior. You could suggest thinking about ways to deal with things when things get in the way. So are there things that get in the way of making a change or cutting back? Are there obstacles? Ask for support from your doctor, your friend, or someone else you trust. So these are just some of the strategies that you can use to offer advice. And hopefully, at least if they come up with one of their own, and they can come up with lots of very creative things, and may not be any of these, is to really support that and to affirm that that they're coming up with their own ideas, and to encourage them to try that. And so say they come up with their own idea, or you've offered an idea and they say, oh, I think I can do that. We don't need them to create a full goal setting or action planning of all the different things they're going to do differently. What we want them to do is to identify something that they can do differently. And it may be one thing, it could be a dozen things, but even one thing is moving them along a process of change. So ask your patients to think of ways to reduce their alcohol-related harms and ways that make sense for them in their life. And here are some of the things that you might hear. And if they can't come up with them, again, you could offer these and say, would you like some other suggestions of ways that you could reduce your risk of alcohol-related problems? Here are a couple of things that have worked for people. Reducing drinking by 1 drink per day. Setting a limit on the number of drinking days per week. Counting drinks, not driving after drinking. So this, is just a very short list. But patients often will come up with at least something that they think that they can do. Certainly, getting behind the wheel of a car or getting in a car with someone else who is under the influence, that may be something you have a real opportunity to talk to them about, and hopefully motivating them and making the connection of why they might be seeking health care at that moment due to an alcohol-related crash or other incident. Here are some of the others that may not come to mind for them, but you might also want to suggest if you think there's a real opportunity to fit this within their lifestyle or ways, or say they're trying to find more healthy approaches to managing stress or coping, or they want to get more involved in exercise or in weight management program. These are some of the things that you could tie that would not only support risk reduction and part of their action plan around alcohol, but would tie nicely with their other goals and things that they're working on. So avoiding triggers for excessive drinking, like going early to happy hours or engaging in drinking contests, developing activities that are non-drinking related activities, eating while drinking so that the alcohol is absorbed more slowly, going for a walk to decompress and to de-stress instead of coming and body splashing as soon as you get into the home, throwing off your shoes, pouring a drink. And the person is really interested in incorporating more exercise in their lifestyle, or you've recommended that for another health-related concern, that's a really good opportunity to pair that, because it supports both goals, as I was mentioning a minute ago. Drinking only during evening meals and alternating alcoholic beverages with non-alcoholic beverages. So what we've talked about up to this point were those key components of brief intervention that I talked about. And so I've talked a little bit about how do you, the opportunities to weave in asking permission and establishing rapport and using a neutral tone and all of those non-confrontational strategies, ways of opening up a question so that it's framed in a way that elicits people to tell you something rather than shutting them down. And so a lot of these that I sort of hinted on are drawn from the motivational interviewing framework. And so we're going to talk a little bit more about those strategies in particular. And I'll talk, mention ways of how you can weave those in to the brief intervention components that we just talked about. So what we know about change is very difficult. And taking the first step to making any healthy change can be really monumental for many people. And so what motivational interviewing is trying to do is to really strengthen the brief intervention, to motivate people to choose to change and to do the work. They have to do the work. They're the expert in their own lives. We can't do the work for them. But we hope that any small change in the right direction is certainly positive and is successful. Brief intervention is successful when we're moving them along risk reduction and behavior change that supports that. So brief intervention techniques and the use of the motivational interviewing strategies are used to explore the negative and positive effects of alcohol use, the pros and cons of their alcohol use. And it explores the motivations to change the negative, the cons of their alcohol use. We use motivational interviewing strategies to explore confidence, that self-efficacy, the importance of making a change or doing something different. And then we explore options, giving them a menu of options and generating even their own menu of options, and plans, helping them to make plans on their own, to generate those ideas and ways of carrying them out. So the conversation is designed to elicit these things for them to have that dialogue and to explore where they are in wanting to make a change. So we cannot provide the motivation to change, and certainly, browbeating and humiliating or using a confrontational style really puts distance between you and the patient, and it really can be very offensive. It can feel very stigmatizing. And so motivational interviewing is really doing just the opposite of that. It's very much having to build up and support and connect and be patient-centered and present in the conversation with that neutral guiding tone and words that guide people forward. So patients are much likely to change their behavior or to move along that readiness to change when you're using that empathic, client-centered, strength-based, focusing on their strengths and supporting their commitment to taking action or to expressing desire to change, supporting that strength and the commitment to even think about doing something differently. And has that motivational enhancing style that's really focused on identifying identifying and solving patient problems. It may be one or two that you're able to tackle in the brief intervention, but those may be very significant. It doesn't mean we have to focus on everything. Well, obviously, we don't have a lot of time to focus on everything, but really focusing on some key things and listening in your conversation with them on what are those key things, and to help solve them and help them to think and do things differently that can solve problems that patients are experiencing. That's what having the motivational brief intervention is about. So as you can see, it's collaborative, it's goal-oriented method of communication, moving them forward with particular attention to the language of change. And it's really focused on intended to strengthen the personal motivation and their commitment to a target behavior by listening and exploring an individual and patient's own arguments for whether they should change or not. And it's not a set of tricks, and some people say it's not really a set of techniques, but really they're strategies. They're strategies for getting a patient to move along on the things that they want to work on. So if maybe we want them to work on many different things and want them to change about their alcohol use, but this is about strategies to help them choose what they want to work on and being with them and okay with what they want to work on, as long as it's obviously healthy and safe. So it's a skillful clinical style for eliciting from patients their own good motivations for making behavior changes on things that they want to take action on. And the goal is for the patient to arrive at these reasons for change that will be the most meaningful to them. So what motivates you or me may not be the thing that motivates them. And for adolescents, if you're working with them, it's not going to be necessarily the health or emotional concerns. It might be that you're working on tobacco because it affects their appearance in terms of acne, active breakouts, that sort of thing. So we have to be thinking about what are the things that really are meaningful to that person that would motivate them. And the goal, it has to be realistic plans for change, and people doing things that they can really act on and can be accomplished within their own set of skills and resources. And then to monitor the steps taken to correct or reinforce change. So when you have opportunities on a next hospital visit or inpatient visit, or they come through another unit of the hospital for a follow-up, it may be that it is a patient who has reoccurring visits to the ED. You have to have ways of identifying, hopefully in your system, that people have been identified at risk. We hope that it's in an electronic medical record or it's in some chart or some way that we know, to explore, if we can, revisit to where they were at that point, and to help guide them and reinforce moving in the right direction, or supporting them in that follow-up visit that they are making changes in the direction in which is more healthful. So here are some of the things that we really want to be listening for. We want to listen for what are their desires for change. What are the things that mean something to them? You may have a patient who has a health condition where no alcohol is safe, and they're consuming at moderate or high risk levels. It's really impacting their health, but they're not really concerned about that. What they're really concerned about is losing their job and being unemployed. And so here's just an example of something that a client had said, a patient had said, I don't want to lose my job because I drink too much. I like working here. I like working where I do, but it's just so stressful. Most of the time I drink to relax from a long day of working, and I really do need to cut down. So this, for example, I'm working with some employers right now who have on-site primary care. And so this actually is not an uncommon example in very high-stress jobs where they have full on-site medical clinics. Really, their job security is the most important, and they know they have health risks. So we have to listen and be in tune for what matters to this patient. Here's another example. I know I have to stop drinking. My daughter is getting so big, and I don't want her to see me as a drunk or as an angry, tired, overwhelmed mother. So her concern is her daughter and how the perception of her. And again, even if she has the most dire health condition and we're focusing on that, that's not her motivation. Her motivation is her daughter. And we need to be able to listen and make the connection that making a positive change will really reinforce to her that she's doing the right thing so that the perception that her daughter has of her is a more healthy one and a better perception. So what we find with people, generally speaking about anything you're making a change about, is that there's some ambivalence. You're going to feel two different ways about making a change. I mean, engaging in a behavior is reinforcing in some way, and not engaging in it, people may not feel so enthused about not doing it because they're getting something out of it. So we know we have the pros and cons, and we have to explore the ambivalence and understand better what motivates people. And so hopefully we can motivate them towards the pros of cutting back and using some of the rulers that I'm going to mention to you. So what we know is that even with wanted or positive changes, ambivalence is often present, and people can continue to be on the fence on things. And we just have to really pay attention to normalizing for a patient, even if it's clear as day and obvious to you as to why this person needs to do something differently. It's normalizing it to the patient and saying, it's normal to feel two ways, about the same thing. On the one hand, it causes a lot of issues and problems in your life, and on the other hand, you really enjoy, your downtime with your friends. So we have to normalize it and say, people feel that way about any change, and that helps establish the rapport that you understand that that they're not like in this exclusive group of people who obviously should be making a change. So readiness to change, there are ways that you can explore that, and we have a couple of you can ask them how ready to change are they on a scale of 0 to 10, and just to get a sort of a temperature reading. Does this person want to take any action? Here's one way that you can talk about readiness to change when your clinical task is to help with the 1 in 5 patients who are ready to make the change right now. Those are very few and far between. So what we found is that a lot of programs and a lot of our approaches are designed for people who are the 1 in 5 who are ready to make a change. Most people are not ready to change. So the 4 out of 5 people we can move them towards motivation and action, those are really the majority of the patients that you're working with. So in a representative sample across more than 15 high-risk behaviors, it was found that fewer than 20% of a problem population were prepared for action at any given time. And yet more than 90% of the behavior change programs that are out there are designed with this 20% of the population in mind. So we have brief intervention, and we're ready to help move people along that change. But you're more likely to encounter the 4 out of the 5 patients who have not even contemplated change or not ready to change. And so we have to be present and work with them and acknowledge where they are. And hopefully motivational interviewing will help you have that conversation to explore where they are and move them forward. So these are the motivational interviewing. This is the motivational interviewing approach. You may be using some of these, so any of these are beginning to sound familiar to you. You may have learned them in a different way. So I would encourage you to think about those things those workshops you've taken, those other skills that you're using already, and think about how they really relate to what we're talking about here. And so I think that there's, what I would say is if you want to become more knowledgeable motivational interviewing, you can take some seminars that really talk about the spirit of motivational interviewing. So if you're looking for courses that can help you become more confident in this area, look for those that communicate about the spirit of it and the fundamentals of motivational interviewing, and those that really emphasize that ambivalence about change is normal. And so if you're exploring a motivational interviewing opportunity and you want to ask us if we know anything about those courses, certainly I've worked with a lot of motivational interviewing trainers. There's a network out there all across the United States who do some incredible trainings. And if you're looking for a high-quality training, I think that's a good first place, a good resource to go to. But if you don't have any resources, you don't know where to go, certainly let me know. I'd be glad to take a look at some of the opportunities that are out there, and if we can connect you with some affordable ones, we would be glad to do that. But I've provided these slides really for you just to give you a flavor, and if you want to look for more training out there, these are the kinds of things that you're going to want more training in, that is going to help you infuse and embed these strategies into your brief intervention. So you really want to make sure that the training that you're getting is going to focus on the partnership. And so when you're having a brief intervention, you have to be, this is a partnership. It's a partnership dynamic, and it's a collaboration, and that's really what we're trying to foster here. And part of it too is evoking, is listening, and the listening from the patient, and providing ways of having a communication that are open. The autonomy, and then respecting that the patient's ability to choose at the end of the day what they want to work on, whether they want to choose or not. So that fundamental spirit of MI, these are really the core things that will really, the strategies or the approaches that you can use in having a brief intervention that will help make your time with them more effective. And so here are the key interviewing skills that we would weave in. There are 8 of them, and the first 4 are micro skills: open-ended questions, affirming, reflective listening, and summarizing. And I was working with some nurses recently in a training, and they said, oh, I've learned this, but in a different way. We called it something different, but this is what we're trained to do. Very quickly acknowledging that this is what I was trained to do. This is what is part of being a nurse, and they felt empowered by the fact that it really aligned well with their training. And so whether you're a nurse or you're another kind of professional, you may see that these open-ended questions, affirming, reflective listening, summarizing, are things that you've been doing for years on other topics. Or it may be that you are sort of getting reacquainted with it. And so hopefully that's what this will help you do. So the open-ended questions, affirming the patient, reflecting what the patient says, and summarize their perspectives on change, are called the micro skills, or the ORs. The open-ended questions, we're not going to spend a lot of time on open-ended questions, but what I would say is that open-ended questions are the most helpful, and we often use closed-ended questions more often than open-ended questions. We're used to getting yes, no, black, white, I take this medication or I don't. I mean, it's very like a checkoff list. We just want to capture very quickly what it is. And it's closed-ended. So we'll say, do you do this, that, do you take this or that? But this is spinning it around and asking to elicit information from them, explore their feelings, or explore, for example, their pros of engaging in risky alcohol use. For example, how do you see your drinking impacting your health? That's an open-ended question that can help you after you've had this brief intervention to elicit their ideas on how this might, and see whether they're in tune with making the connection to the health issue they may be presenting about that is alcohol related. How would you describe your relationship with alcohol? That's another example. And here are just some that we commonly see in ways to help you spin them around. If you're doing some clinical supervision, or again, you're working with colleagues or so forth, trying to be in tune on how you phrase questions can be very helpful. So try to
rephrase so that you're using more open than closed. For example, so you were here because you were concerned about your use of alcohol, correct? So that would elicit a yes, no, closed-ended response option. Another way to phrase it in an open-ended style would be, tell me, what is it that brings you here today? Something you may already do, but again, I think it's more about the ratio in which we use them that helps us facilitate the conversation. Another example, do you think you drink alcohol too often? No. Another way to phrase that would have been, in what ways are you concerned about your drinking? Did you know there are several medications available to help you stop drinking? No. You could phrase it, there are several medications available to help you stop drinking. How do you feel about this idea? When do you plan to quit drinking? An alternative would be, so what do you think you want to do about your drinking? So I would even encourage you to, if you want to do brief intervention, is just have a little mini session with staff to help them rephrase the dialogue, to have a more fruitful conversation about behavior change. So affirming your patient, this is really, again, focusing on the strengths, encouraging your patient's persistence in spite of past problems, point out and celebrate the steps and successes they've taken so far, acknowledge the positives, remind your patient of the past successes, compliment willingness to talk about difficult issues. And here's an example. Thank you for taking a few minutes to talk to me about your alcohol use. I appreciate your openness and sharing your experiences and thoughts with me today. I noticed that you were really good at identifying strategies which help you reduce stress. You really showed a lot of strength talking about quitting smoking. This can be really challenging. So affirming and acknowledging those strengths. The other micro skill is utilizing reflective listening. So ideally, most of the time you are in the brief intervention, you are listening rather than talking. And it could be that you're just paraphrasing. You may be repeating back to what they say, but often it's more about taking what they say, reflecting back that you heard it correctly, and paraphrasing it to make sure you understood what they were inferring from what they were trying to communicate with you. And then it allows you to clarify if you heard them correctly. They have the opportunity to correct you or to explore further some of the things that are concerning them that they really want to talk about. So the primary goals are to help you accurately understand not just what they're saying, but what they mean, what the underlying meaning is, and help the patient to clarify their own thoughts. So when they hear it back, what they've said from you, they're hearing themselves talk. And it sounds different sometimes when it's coming from someone else. And it gives them a chance to clarify in their own mind if that's what they meant, and even to think about what that sounds like when they hear it. And there are several phrases you can use to clarify and reflect back to make your understanding what your patient is trying to convey. You can say, I understand the problem is, or I'm sensing, I wonder if, I get the impression that. So someone says, on the one hand, I really, enjoy hanging out with my friends, and I like, Sunday night and Monday night football, and I really like, partying with, all of my family and friends. But at the same time, I feel really hungover, and I come to work late, and I can barely function. So you could say something like, I get the impression that work is important to you, and coming to work, ready to work and productive and not hungover is important to you, and you would like to be able to do that. So reflecting back, so you didn't say exactly what the person said, but you reflected the meaning, what they were trying to convey to you. Or where you're coming from is that you really like to spend time with friends and relax, and that's your way of relaxing, and it really makes you feel like that you're de-stressed. At the same time, on the other hand, you've experienced some some real problems. You had an alcohol-related injury on the job. You had a DUI, and so I think I understand that you're in a difficult position because you really are experiencing some difficulties, but you really enjoy that time. And so it's reflecting back in a way, and they could say, oh no, this is their opportunity to say, no, that's not what I meant at all. And if it is, that's a really good opportunity to clarify for you really what's motivating them. So here's an example of how you can use it without repeating exactly what they said, but reflecting it back in a way that has the same meaning, but the patient never thought of it this way. So the patient says, I don't have a drinking problem. I just drink 4 or 5 times per week and with my friends. And the health professional says, okay, so you drink more days than not during a week, and you do not feel that you have a drinking problem. You're saying the same thing, but in a very different way, that the person has now realized that you've interpreted this as they're drinking actually more often than not. But then that is not likely how they thought of it, and that's a different meaning, and it sounds different to the patient. So they have to think about, oh, okay, so I'm drinking, it's right, I drink 6, yeah, I drink a lot. I drink more often than I don't. And so it just gives them another way of thinking about it, and you can express concern here. You can pair it with your expression of concern about that. And summarizing their thoughts. So this gives an opportunity to show the patient that you're actively listening, you're remembering what they've said in the conversation, you're reinforcing information and bringing to focus the themes that they've talked about, the things that concern them, the things that, the cons of cutting back, for example, the pros of doing something differently. There are lots of different themes that could come up, but summarizing them for the patient, their thoughts and their feelings, shows that you've listened to them. And it provides an opportunity for them to hear what you've learned and what you've interpreted and the meaning you've gathered from what they're saying. And then an opportunity to correct or to reflect back that, yes, you did get that right. And so you have an opportunity to clarify to make sure that you understand what's motivating them or their thoughts or their feelings. And it can also just allow you to bridge the conversation. So if you're at a place where you're trying to move the conversation along and you need to move on to talking about other things, summarizing is a really nice way to bridge moving from one topic to the other. And so you can also, before you move to the topic, you could say, so did I get that right? What else? Did I miss anything? And then, if there is, certainly the patient is more likely to come forward and say, no, you didn't get that right. But this is just a nice way to then move on then, into the next, say, brief intervention or screening or other patient health concern you need to talk about or whatnot. So I already said that. Let's see. So eliciting change talk. Here is an opportunity, some cues of ways of getting people to talk about change. We talked about people are not always ready to come in and make that change. And so understanding that there are negative consequences of their change, of their behavior, can really be a barrier to them. And so if we can help elicit reasons for change and work through their concerns, they're more likely to move forward. But we want them to elicit the change rather than us telling them why they should change. And we want to really guide them or coach them to help them figure it out and help them create the plan and help them create the reasons. And what we often talk a lot about in motivational interviewing trainings, and something you'd also want to look for is trainings that focus on change talk. How to elicit motivational statements that desire the need for change, to encourage change talk, And these are statements said by the patient that favor changing that unhealthy behavior and describes the reasons or advantages of changing. And so we really are hoping that if we can elicit at least one something that expresses that they're making that statement towards change, it helps the patient develop the awareness of their own motivations. So I don't want to lose my job because I drink too much. I like my job, but it's so stressful. Most of the time I drink to relax from a long day of working, and I have to cut down. I really thought I had my drinking under control, but I can't seem to stop this depression I've been in. Maybe I'll feel better if I get this drinking under control. So these are the kinds of change statements, and we want to be listening for their motivations to change. And this is an opportunity now to explore the pros and cons of drinking and how that might impact depression or symptoms of depression, and explore their readiness, the importance and confidence to make a change. And eliciting those change statements and having them elicit them can be very powerful. And there are a couple of ways to do that. One way is using evocative questions that are open-ended, and the other is the readiness rulers. So evocative questions are questions or that you pose that are eliciting them expressing desire to change, ability to change, reasons to change, need to change, and commitment. And this is often called the darn C. So you would want to look for that also. If you're looking for motivational interviewing training, how do you use the darn C, and how do you elicit these using these evocative questions? So how would you like things to be different? How did you stop before? What are your concerns about your drinking? Why do you think that you need to stay clean? What do you think you will do? And here are just some more examples for you that you can use and you can refer to when you're thinking about what you want to do in your own hospital settings, just to help you write some scripting and some ideas to really get you started. And then readiness to change. There are a couple of different rulers that are out there that you can use around alcohol use, tobacco. Readiness rulers have been used for many things in terms of behavior change around, let's say, diabetes, medication management, behavior change. And you may be familiar with some of these. One of the readiness rulers looks at using it in the context of how important a change is and how confident they are to make that change. And it's done on a 0 to 10 scale, from not very confident to very confident. And one way of exploring someone's importance and readiness to make a change and something they've identified on their action plan is how important, or what is the current value of that change to the individual. So you're looking for things like, I want to stop drinking because it's getting harder to get up and to get to work on time. I could lose my job because of it. You're hearing them place importance on that. On a scale of 0 to 10, how important would you say it is for you to reduce or stop drinking, with 0 being not at all important and 10 being extremely important? Or you could say, on a scale of 0 to 10, how important would you say it is for you to reduce or stop drinking and to be able to get to work on time, with 0 being not at all important and 10 being extremely important? So again, you can use these rules to adapt it to those change statements or reasons for change, desire to change that you're picking up. So if someone says a 6, you could say, well, what led you to a 6 and not a lower number like a 2? So you're always starting with the higher number, so that you're expressing to them that they must feel that this is somewhat important to them. What would it take to go from a 6 to a 7? Getting them to articulate how it could become more important. Confidence the same way. I would really like to quit drinking, but I'm not sure that I can. I've been drinking for so long and I haven't been successful in the past. So they're expressing a desire, but they may not have the confidence. So we want to help move them along and feel more confident. Part of it, building the self-efficacy. So on a scale of 0 to 10, how confident would you say you are about being able to stop drinking? 0 being not at all confident, 10 being extremely confident. Or on a scale of 0 to 10, how confident would you say you were able to cut back on your drinking and to get to work on time? So if they say a 4, you could say, what led you to pick a 4 and not a lower number? To help to acknowledge to them that they must feel some confidence. And rarely would ever, I've never heard of a case where someone picked a 0. I guess if you did, you could say, well, why aren't you a -1? But, you know, wherever they are is saying, well, why are you a 4 and not a 2? What would it take to make you feel more confident, a 5 or a 6? So you can pair this with one of their action plans, one of the items on their action plan, and explore how important and confident it is to make that change. Here's a nice pocket guide which you have as a handout that you can download, which people actually use in hospital settings in primary care. It prints out very nicely. Colorado SBIRT developed this card, and it provides a way of like a pocket guide of showing the person the level of risk where they are, reminding them of what a standard drink is, the low-risk drinking limits, and you can even have a brief intervention, a screening and a brief intervention just around this card. And then at the bottom you have how ready are you, how confident are you, how important are you, and the 0 to 10, again, whatever they are identifying and the desire, need, ability, that conversation to change, you could use this card to have that conversation. There are also other protocols available to you that are much more in-depth that put all of this together. So if you want to use the card plus the other protocol handouts, which are like flow sheets and checklists, which literally take all the information I've talked with you about today and putting it into a workflow, into a checklist, something put on a clipboard, something that's, you know, a front and back, something that's a couple of pages. All of this and the scripting are in some of them. In others, they don't have the scripting. Like in the card, obviously there's not enough space for the scripting, but some of them, you know, people learn the dialogue and learn how to have the conversation, and then they can move to a protocol that has less scripting and less prompts for them. So there are different ones based on where you are in your learning and different ones based on just what you want to go with that really works with your setting. But I would encourage you to ask permission along the way when you're giving normative feedback, if you're giving advice, if you're giving alcohol education, just ask permission to give it. And we also want to, you know, keep in mind that people may they may say no. They really, they have that, we have to respect that they say no, and it may be that the next provider they encounter and in that process of going through your setting, they may be more willing to that second person they're handed off to be the source of their own ideas and to have that conversation and to begin to feel like, well, maybe this is a safe place to have this conversation. So, you know, there are really multiple opportunities, and we want to provide, you know, a place for them to have the assistance and the support to explore, and asking permission along the way is really is just a really good way to do that, and to hopefully get them to explore with you a lot of the things that we've been talking about. And there are really, you know, we say that in asking permission, there are really limited places where we want to ask permission, and it's when you specifically ask, the patient has specifically asked for your expertise or has granted you permission, or they're headed in a wrong direction. So those are sort of some of the things we talked about and some of the obvious if it's a harmful situation. And then generating a menu of options. This is giving your client, your patient, the opportunity to come up with alternative solutions to their own behavior, evaluating and choosing between the options, and testing those choices, or testing whether those things work for them. So they may have an action, they may go out and try it, and it doesn't work so well. But if they have other options available to them, they may decide to go a different course and try those. And they may get to the same goal, but it may be just a different path, and having different options is very is very useful in encouraging that so if they don't do so well in the face of the challenges and that action, they can at least try something else that will get them to the solution. So you can ask them, well, what changes are you thinking about making? What do you think you will do? What can you do tomorrow? What could you do today? What do you see as your options? So I think some will know what some of their options are, and some may not be familiar with options at all. And so you can certainly help them create a menu of options of things that they can do different. It may be the options exploring different types of treatment options or supplemental support groups like mutual support groups, helping them generate a list of things and to explore them, take them home and think about them, and giving the contact information for those is a good first step in this brief intervention. But we want to make sure that the options that they come up with are specific, they're meaningful, they're attainable, they're realistic and time-bound. And you may have heard of SMART goals. Well, that's exactly what we want them to do now. They have to be within that SMART framework. A couple of options to prompt them to begin to think about what their menu of options are is what will be your first step? What will you do in the next 1 or 2 days? What might get in the way? How will you deal with those challenges? So when they select an option, they have a path forward where they can think about what are the challenges they may encounter and try to solution them before they encounter them. We can't buffer them from all of the different challenges, but it's likely they could come up with an action plan just to deal with the challenges as they're trying to explore that option. So in the Health Professionals Learner Guide, if you want to order a copy or if you just want some specific tools that I'd be glad to send you separately, we have some setting goals for change exercises so they can explore and write down what their menu of options are, a change plan worksheet that they can work with you on right there or take home. I'd be glad to send those to anybody who's really interested in some of the additional resources around those. And I would also mention to you that we have a number of additional webinars that talk about some different support group options, treatment options. We have some great resources on medication-assisted treatment, on mutual support groups, alternative support groups. So if you want to learn more about those, also in the professional guide, there's a comparison chart of the different types of support groups. Lots of resources in there if you want to become more familiar if you're trying to help your patient generate a menu of options. And I'm not going to talk a lot about managing pushback because that's a seminar on its own. But if you want to, for clients that are pushing back, I would say there are some opportunities to get some additional training on working with patients and how to roll with that pushback and not to confront pushback and recognize that there's something going on with that patient that in them makes them uneasy and why they're pushing back. And it could be fear, it could be all sorts of things. But I would say that we just need to acknowledge that it's there. We need to move forward with it and getting some additional training on how to manage pushback if you're doing a lot of this work could be very, very helpful to you. And I have said that. And let's see, the easiest way I would say is one thing to take away on managing pushback, though, is to say, I hear what you're saying and I can understand why you feel that way. So if that's all you feel equipped to say, at least in the moment, that's one way of handling pushback. So there's one takeaway from this that I think can be very useful at all different levels of beginning to use these kinds of skills. It can be very good in neutralizing the conversation. So bringing it all together, we've talked about screening. We focused a lot today on brief intervention and just some highlights of motivational interviewing. We'll be talking about referral to treatment on Thursday the 27th in our Part 3 webinar. And I'll leave you with this. Suitable methods of identification and readily learned brief intervention techniques with good evidence of efficacy are now available. The committee recommends broad deployment of identification and brief intervention. So we're now moving this and all that we've talked about today into being more routine practice. But we started, this statement came out 22 years ago. And so with folks committed, like the folks that are attending this webinar and your organizations committed to doing this, we hope that in some small way what we're sharing with you will help you really move this practice into being routine, standard ways of operating. And so we're here as a resource to help you do that. So again, more resources available to you in the guide if you'd like those. And in your handouts, before we close and open up for questions, I want to point out the handouts to you. We have put together a number of protocols for you that provide all the scripting that we have gone through today, whether you want to use the audit C alone, whether you want to use the full audit with brief intervention without any motivational interviewing. That's the second one. If you want to use the audit plus all the motivational interviewing strategies we've talked about today, you have a third option for a protocol. And then if you decide you wanted to do follow-up, we have a protocol that provides scripting around how to do follow-up, how to introduce it, and so forth. That is available in your downloaded handouts. This is what they look like. So they're not, they aren't glossy and pretty. We put these together in a lot of the studies that we've been conducting and have been found they're very, very useful. And you'll see it walks through introducing the screening that we talked about in part 1, how to introduce the audit and the scoring of that, to provide the brief intervention response and to interpret it at what level of risk and what goes into that intervention. And then it'll go further into breaking down that audit score feedback, the alcohol education, the normative feedback, how to provide education materials, how to close on good terms, asking permission, providing referral. All of these handouts are available to you that look like this, and you'll see that the scripting is very familiar to you. And again, looks the same. This is the one for the MI Informed, and it weaves in all the motivational interviewing strategies. As you can see here, it prompts the professional to use their open-ended questions, their micro skills. It will prompt them along the way, as you can see on the right-hand side, to affirm, reflect back, and summarize, so forth. And then here's the guideline. I talked about the ones that don't have scripting available to you, but have nice, like, little lead-in prompts of a workflow process. This Colorado SBIRT Clinical Guideline prompts you to ask and screen and to provide a brief intervention. All of these are in the public domain, and you can see it prompts you to provide feedback at the different levels of risk. And then if you're working in trauma and ED or other really fast pace where you have a kind of initial process, we've developed this checklist which will allow you to take some critical, like, patient information for documenting, how to open up the brief intervention, how to screen, what you do with a negative screen, what you do with a positive screen, what you talk about in the brief intervention. It's based on what we call the flow, which is developed by Chris Dunn and Craig Field. If you're familiar with the flow, and you use it, this is a nice way to pair the flow with the audit. And then here's the original flow. This is Chris Dunn and Craig's work. And if you want to use the original flow, we've provided that here for you too. So all of these are sample protocols that are available to you in the public domain. And so if you have any questions about how to use them, please don't hesitate to contact me. So thank you for listening, and please join us for part 3 on Thursday. And here are links to the archive and how to register for the upcoming webinars. And we're going to open it up for questions.
Thanks so much, Tracy.
So